Hello everyone, my name is Caroline Lecalvé. I am a research assistant for the Computational Oncology Group at Imperial College London. I am glad to talk today about the challenges and approaches to routinely collect patient-reported outcomes measures in cancer patients. But before explaining the challenges encountered, we need to understand the background and why it is important to capture PROMs data. I'll present the two projects we designed and implemented to capture PROMs, and especially what we understood from these. As I know the audience consists of people with various backgrounds, a few key facts and statistics to grasp the cancer situation in the UK. Over the last decades, the cancer incidence rates have increased and they keep increasing. However, the rate of patients surviving cancer 10 years post-diagnosis is also improving. Therefore, NHS England now describes and considers cancer as a chronic disease similar to diabetes and asthma. Obviously, survival varies across cancer types. For example, almost 80% of breast and prostate cancer patients will survive for 10 years or more, whereas only 10% of lung cancer patients will reach a similar survival. When patients are diagnosed with cancer, they will be offered surgery, chemotherapy, and/or radiotherapy. Clinicians will estimate what sequence of treatments are best for the patients according to their primary diagnosis. In parallel to the treatments, we have the patient-reported outcome and experience measures. They are tools designed for and used by patients to assess their quality of life and experience at various time points during and after treatments. They are usually used during clinical trials, but rarely in routine clinical practice because they can be time-consuming for staff, especially if they are required to have a long conversation with each patient. So, if these tools can be time-consuming for both the clinical staff and the patients, why are they so important to capture in routine clinical practice? Let us compare what clinicians are interested in versus what patients want. During a consultation with patients newly diagnosed, clinicians will discuss the diagnosis, the survival rate, the treatments available, and the side effects, and they will also ask about the patient's family history, as some cancers can be influenced by genes. On the other side, patients will have similar concerns that clinicians will easily answer, but there is one blind spot that clinicians can only estimate, and this is the patient's quality of life during and after treatment. I say estimate because most of the data are based on clinical trials where patients recruited are usually younger and fitter than the average population treated routinely. Therefore, we try to find a way to bridge this gap. The starting point was a project named Trigger. It was launched in July 2018 and it officially terminated in July 2021. Trigger was designed for patients with pelvic cancer and having curative radiotherapy. Like a clinical trial, patients had the choice to enroll in this QI project and the decision had no impact on the treatment. For the patients who enrolled, they were asked to answer the questionnaire displayed on the right-hand side of this slide at the end of their treatment and then every 3 months. Over 3 years, 4 centres in the UK ran Trigger by using an NHS independent secure online platform. Although the results are important in this context, it is important to compare the initial idea to the idea implemented. Indeed, the final solution chosen, which was easy to implement, scalable and accessible to any centre in the UK, was totally different from the initial idea. The initial idea was simple for patients, but not scalable. Patients will finish their treatments, come back a few weeks post-treatment to have a 10-minute conversation with the radiographer who would record their side effects and then record them into the National Radiotherapy Database. There were multiple issues with this idea. First, radiographers do not have the time to have a 10-minute conversation with each patient diagnosed with a pelvic cancer. We need to remember that there are almost 50,000 new prostate cancer cases in the UK every year. Radiographers do not have 500,000 spare minutes per year. The second main issue was that the National Radiotherapy Dataset was not designed to record PROMs data. The solution implemented was based on EasyJet, where we let the patients do most of the work as they know their own data. The patients had a leaflet to take home with information on the project and a link to the website to register with their email address. Then, every 3 months, they received a reminder to complete their questionnaire. The platform was independent of the NHS systems, hence the ease to install. When we started this project, we did not want to collect the data with no benefits to the patients, as patients would not be motivated to enter their data with nothing interesting in return for them. By registering online, they were able to monitor the side effect post-treatment without help from their treating team. They could also see the improvement of their symptoms over months, as data was recorded and displayed immediately on their profile. They could also complete the questionnaire as often as they wanted. They did not have to wait a 3-month limit. When they finished to complete their questionnaire, and if they answered positively to at least one question, they had a message that advised them to book an appointment with a treating team, and a phone number was provided depending on the center they were treated in. With the EasyJet solution to capture PROMs in pelvic cancer patients, almost 900 registered over 2.5 years and across 4 centers. This is the biggest PROMs dataset of the country. However, almost 900 patients represent less than 20% of patients who were eligible to participate in this project. When we asked the patients the reasons they declined, they did not feel comfortable using a computer, or they did not have anyone at home to help them. For the patients who did register, the reminders were beneficial in the completion of the questionnaires, as we can see on the graph. When we asked feedback to the patients who registered, we realized that there was no clear benefit to them, as they had regular contact with their treating teams, so care was always provided to them, one way or another. Furthermore, when we asked clinicians what they thought of the NHS independent platform, they explained it added a new layer of complexity, as it was yet another standalone system, and they had to connect to it in order to have information on their patients. The Trigger project helped us to understand the challenges involved in collecting cancer PROMs in routine care and at scale. Although uptake was low, it represents one of the largest pelvic radiotherapy PROMs datasets in its existence. Using a standalone platform made it easier to implement Trigger, but the lack of integration reduced its use and made it harder for clinicians to access the PROMs data. Although uptake was low, it is similar to that seen in other work outside of small feasibility studies. We are planning the CURIE Indigo project as a follow-on. This will be built using systems that integrate with trust systems, and the focus is on one delivering patient-centered value from PROMs collection through alerts, symptom summaries, and access to social prescribing. To design CURIE, we looked back at what worked in Trigger and what did not, and what could be improved to make it more appealing to both clinicians and patients. One of the first conclusions we had with Trigger was that it took the same amount of time and work to design and implement a project suited for pelvic cancer patients. CURIE is designed for any adult cancer patient with an access to internet and starting a new line of treatment. Like Trigger, patient registered, consent, and answer questionnaires online. The difference with Trigger is that we want to capture demographics that are rarely captured in routine practice, such as disabilities, sex of birth, gender, patient's preferred name, etc. At the start of the treatment, we ask patients to enter what they think the diagnosis and treatment are in order to compare to the local system. And then, at the beginning of the treatment, then every 4, 8, and 12 weeks, patients can complete a quality of life questionnaire, a few questions about their experience during the treatment, their hospital admissions, and their future clinic appointments to get reminders. Ideally, the platform should be embedded in the hospital's PAS system, so the PROMs and PROMs data are directly linked to the patient's electronic health records, and clinicians will not have to connect onto different platforms to get a full picture of the patient's health. We realized the benefits set in Trigger for the patients were not as beneficial as we thought they would be. With the help of patients and staff, a new set of values were designed. Since patients mostly want to focus on quality of life, the questionnaires were largely around this theme. Patients should be able to bring a summary of their concerns and wants to the clinic appointments to discuss these with the treating team. Depending on what patients need, clinicians can refer the patients to communities and charities that could help the patients. This is called social prescribing. This is not an active treatment, but still a support that patients, families, and carers may not be able to provide. Finally, patients can identify issues taking place in the department that managers may not be aware of, but they can work on to improve other patients' experience. For example, we know that waiting times in clinic can be long for some patients. We cannot fix this issue, but we can prevent patients' frustration by warning them and acknowledging this problem. The issue will not be fixed, but at least patients will feel listened to. To summarize, the amount of work to capture PROMs in pelvic and in adult cancer patients is the same, except that CURIE captures more patients with sometimes rare disease. Although it is less scalable than a standalone platform, the platform should be embedded in the trust to ease the access to the treating teams, and patients should still complete most of the demographics and the questionnaires. Since we know that patients are people first, they need to be reminded to complete their questionnaires before a clinic appointment. To increase the registration rates, patients should hear about the projects during all their patient journey and from different members of their treating teams. Otherwise, it is less likely they will register at the end of their treatment if they hear about the project only once from one member of staff. This project would not have been possible without various people's help, such as Dr. McNair and Dr. Williams, who had a big influence on both Trigger and CURIE, along with other staff, patients' representatives, and charities actively involved in the design of CURIE. Thank you for listening, and if you're interested to know more about CURIE, feel free to visit the official website that is displayed on this slide and to contact us using the email address also displayed on this screen. Thank you.